Thank you very much, Jenny, and Adnan for setting the stage on actually what we have clinically. I'm actually really excited to present it and to present in this symposium because, you know, there are many symposia and there are many new drugs, exactly like you showed, and many of the new approaches are excellent in solving the issue of burden, like everything, allowing a longer interval between injections and reducing the burden on the patient and on his family and on us. But until now, we didn't see a lot that actually improved the visual acuity. And I think that every retina specialist here in the audience and in the meeting, if you ask him what is the main limit now for the treatments that we have for neovascular macular degeneration, almost everyone will say that it is, yes, the burden, but also the limitation on the final visual acuity. So I'm really excited to present in this symposium and to present on this particular drug. So I'm going to elaborate on how Sozinibercept can really raise the standard of care benchmark in terms of visual outcome in our patients. These are my financial disclosures. I will start by reviewing the phase 2b trial results, and then I'll also tell you about the phase 3 trials design. Let's start with the phase 2b trial results. Here you can see the trial overview. It's important to note, you can see my mouse, that patients to be included in the study, patient had to be treatment naive with neovascular macular degeneration, with an active lesion of at least 50% and a visual acuity as actually conventional in neovascular macular degeneration trials, and also with acceptable inclusion criteria. Patients were randomized, and it's a pretty large number of patients for a phase 2b trial. So patients were randomized to either sham plus ranibizumab or Sozinibercept in one of 2 doses. Patients were receiving treatment monthly, and you can see that basically a large number of patients completed the study, which is always a good sign for a study. The primary endpoint was the mean change from baseline best-corrected visual acuity at week 24. There were many secondary endpoints, like we are used to have, functional ones, the percentage of patients gaining more than 3 lines of vision at week 24, and morphological endpoints, change in central subfield thickness at week 24, change in intra and subretinal fluid from baseline to week 24, and of course, safety and tolerability. There were some pre-specified subgroups. First of all, the lesion types, predominantly classic, minimally classic, or occult lesions. We wanted to look specifically at RAP and at PCV. So it's actually exciting to show the results. The phase 2b primary endpoint was achieved with a delta in best-corrected visual acuity change of plus 3.4 letters, which achieved statistical significance. Just to remind you, the patients that received either sham with ranibizumab or Sozinibercept in one of 2 doses with ranibizumab. When you look at the other parameters, you can see that patients in the combination arm had a higher percentage of gaining more than 3 lines of vision, of gaining more than 2 lines of vision, and of gaining more than 1 line of vision. So same trend. When we're looking at losing visual acuity, patients in the combination arm had less chances to lose 3 lines, 2 lines, or 1 line of visual acuity. When you look specifically at the predefined subpopulation in the occult and minimally classic lesion, you can see that patients in the patient in the combination arm had a 0.5 plus 0.7 letter gain over the standard of care based on this predetermined analysis. And just to remind you, these patients are most of our population. The higher patients in the combination arm in this subgroup achieved a gain of 3 lines, 15 letters, 2 lines, 10 letters, or 1 line, 5 letters. Again, fewer patients lost vision in the combination group, which is in this subgroup, minimally classic and occult without RAP. Basically, no one lost 3 lines, no one lost 2 lines, and much less patients lost 1 line. These good and functional outcomes were paralleled by anatomical outcomes. So, reduced retinal thickness and better retinal drying was observed with the combination therapy in this subgroup, with patients in the sham group having less reduction in central subfield thickness, having higher percentage of subretinal and intraretinal fluid. We always want to know how many patients remain with functional vision. And it was nice to see that there was a 42 relative increase in percentage of patients with a functional vision at week 24 compared with the ranibizumab alone. Another parameter that we are looking at is the CNV lesion size. And in the combination therapy, in the occult and minimally classic no-RAP lesions patients, the mean change in total lesion size was greater in the combination group when you look at the total lesion size and at the CNV area at week 24. The safety was excellent. It was well tolerated and really comparable to the standard of care that we really know so well of ranibizumab given monthly. Specifically, when we want to look at ocular treatment emergent adverse events in the study eye and in the severe ones, and in intraocular inflammation, something that always interests us, and the adverse events that are leading to treatment discontinuation, or any thromboembolic events, there was no sign of safety signal or any difference from the standard of care. So we have very good, promising data from the phase 2b trial, specifically when we are looking at the main population, which is minimally classic and occult lesion. This led to the phase 3 trials, Coast and Shore, of which I'm sure that many of you are investigators in. So these are the pivotal trials that will serve for registration of the drug, and they're actually optimized after the phase 2b trials. So let's look at the sequence of events. The phase 1-2A had treatment-naive or prior treated AMD patients that had 3 monthly dosing. The phase 1b/2a had 3 monthly dosing. They were pre-treated DME patients. The phase 2b, which I just showed you, was the treatment-naive AMD. And now we are talking about the phase 3 trials. So these are actually 2 trials, the Coast and the Shore. And the top-line data is anticipated in mid-2025. The comparator in the Coast is aflibercept given per the label every 2 months after 3 monthly loading doses, and the comparator in the Shore will be ranibizumab given monthly. The aim of the trial is to look at standard dosing, extended dosing for both trials. It is a multi-center, double-masked, randomized, sham-controlled treatment-naive patients with neovascular AMD trial. It's a large trial with almost 1,000 patients per trial, and the comparators are the two drugs that we use mostly. And the regulatory quality is of 90% power, 5% type 1 error rate. Here you can see the design of the trial, and it's actually a design that will support potential very broad label for use with any anti-VEGF therapy. We are comparing it to monotherapy with the drugs that we most often use. So following a loading dose in the COAST trial, patient will be randomized at a 1:1:1 ratio to either aflibercept given per the label or aflibercept with sozinibercept given every 4 weeks or every 8 weeks, standard to extended dose. The primary efficacy will be measured at week 52, but safety data and also efficacy data will be measured at week 100. And a very similar design is looked at for the ranibizumab trial, only that because ranibizumab is given monthly, then this is the difference in this trial. The enrollment for both trials have been complete. To be included in the trials, patient had to have a best-corrected visual acuity score between 60 and 25, letters in the study eye, active, subfoveal or juxtafoveal, which will help the broad label, with foveal involvement that is secondary to AMD, and the usual exclusion criteria, mainly other diseases, any other previous treatment for AMD, or anything social or psychological that prevents the completion of a trial. The primary outcome would be the change in best-corrected visual acuity at week 52, and there will be other functional outcomes, as we are used to see, of loss of 3 lines, 2 lines, and 1 letter, and also changes in choroidal neovascularization area and proportion of patients that don't have subretinal and intraretinal fluid. I'm very optimistic about the phase 3 trial results. It's a novel mode of action, like has been shown to you by Adnan. It's a potent trap molecule that neutralizes something new, VEGF-C and VEGF-D. It combines nicely with the anti-VEGF that we know, as we saw in the early phases trial. And I think it has the potential to be part of our standard of care of our macular degeneration patients. So we will move to the panel discussion, and we do have microphones. You can also submit your questions, and please, we are really, really open to questions and arguments and comments and whatever any of you want to express. Someone going to the microphone? Okay. So let me start by just asking the panel. If you see this patient that comes with significant intraretinal fluid, what would be your drug of choice and your primary treatment goal? Adnan.
So Arshad asked me a similar question about the drug of choice on the NHS. We have access to all 3. And I'd be equally happy with any of them, and I think we'd get probably a similar response in terms of fluid reduction and acuity benefits. Slightly controversial, but I'm pretty neutral about the relative difference in efficacy of visual acuity gain.
So what are you doing? Tomorrow, you see this patient now?
3 injections and then treat and extend of either Eylea HD or faricimab. Honestly, wouldn't mind.
So how do you decide?
Sorry?
How do you decide? I remember that Neil Bressler used to say in the old days
so what happens
that he's doing the right eye with ranibizumab and the left eye with Eylea.
Often it's a patient perception. So patients and physicians are like the new and the shiny. So we have access to faricimab. So recently a lot of new patients have started on faricimab, and Eylea HD has just become available. So patients like the new. So we're often persuaded by our patient's choice.
Jenny?
Yeah, I agree. All of them I have no problem starting on any of them. Access is an issue with our part of the world, and a lot of the choice currently it would be based on the claim to durability. In terms of visual acuity outcome, it would be very similar between them.
So what are you doing? You have this patient in your clinic tomorrow.
Well, for our part of the world, a lot of patients will start off with the more economic choices. For example, Lucentis is heavily subsidized in our setting, and then we will see the response after 3 treatment and then decide whether to continue.
So when I gave my list, I didn't include Lucentis. It's not because I don't think it's an effective drug. And one thing most people forget, but given that I was back in the day part of the original trial, that the visual acuity gain point estimate with monthly Lucentis was actually slightly greater than Eylea fixed dosing, but the extended durability was non-inferior. So in fact, the phase 2 trial here is against the most robust standard of care for visual acuity gain, which is fixed dosing monthly Eylea. Everything else is non-inferior, but marginally worse. So even though I didn't mention it, that's because of the perception of extended duration on treatment burden of the other drugs. But those trials didn't robustly answer the question about extended duration. Controversial, I know, but as a data purist, that's how I read the data.
Okay. So just to remind, this is a phase 2b case with a treatment-naive the patient receiving 2 milligrams Sozinibercept and ranibizumab combination. It's difficult to say a type of a lesion from the OCT, but it was coined as a predominantly classic one. And you can see that there is a very, very nice response in this particular predominantly classic patient. So I would like you now to look at this question, the audience, and to ask what is your primary treatment goal with anti-VEGF therapy at 12 months. It's a patient that has this very significant lesion, has subretinal, sub-RPE fluid, intraretinal fluid. To vote, you need to scan the QR code here or go to the voting tab in the Euretina application. So please start voting on what is your goal. Do you plan to see some moderate vision gain? Do you want to see improvement in vision gain? Do you want to see stabilization or resolution of fluid? Please start voting. Okay, so interesting. 40% voted for achieving 20/40 or better vision. What is your goal in these patients?
Ultimately, it's about function for your patient. So I would agree with the majority of the audience. And you assume the other parameters would follow that sort of great visual acuity improvement.
Jamie?
I agree. That is the proof of the pudding. Without knowing the starting vision, patient may improve 15 letters, but we don't know what is the starting vision. Ultimately, what we want to get our patients to is that 20/40 or better.
Yeah, so just to add to that, one of the things is on those big data sets we're looking at in the UK, we now in the UK have every single centre have to submit the data on every single patient in the UK to look at how variable our centres are. And one of the things, your ability to improve vision is so dependent on your starting vision. And what we have set as one of the important metrics is 6/12 or better, because that's a holistic pathway of what's important if you and maintaining good visual function in patients. So I think that's a really good metric.
Yeah, I think theoretically the long-term goal would be really to achieve functional vision, but on the what I want to achieve every day is to dry the retina. You know, this is how I treat the patient. But then at the end of the day, what I really want is for him to stay with good vision.
Anat, may I add? But
sure.
I think all of us have seen the kind of patients who come to our clinic and say, my vision is still not good. And then we try to say, but it's improved a lot already, but it's actually anatomically so much better. And we have to use those and show them the OCT to kind of reassure them. But really, it is how they feel their function, the visual acuity improvement that really the patient sees themselves.
Yeah. So let's say it's a naive patient. Theoretically, this patient receiving a combination could really achieve your goal with a nice improvement in visual acuity if it's a patient from the trial, and he could really achieve a goal of a nice improvement in visual acuity. So we do have hope. As I said today, I'm just saying that most chances you'll have a stable visual acuity, small chance to improve, and I look forward to being able to say more than that to my patients, exactly like you said. So I have a few questions to you. So first of all, you know, the combination therapy has a lot of potential. How practical is it to actually do combination therapy, to use 2 injections for the patient on the same day?
So we've had other trials where we've had to do 2 injections, and I don't think that's an issue. And I think initially people in other trials separated them, but we know with a certain gap and no history of massive pressure spikes, which you could pre-treat, having a gap and treating on the same day would be how we'd eventually deliver these therapies. So it wouldn't increase the burden of visits for your patients.
So would you wait between the injections, or would you just continue?
So what we've done, I'm not part of this current trial, but in other trials I've been part of where we've had 2 injections, it's usually a half-an-hour gap.
Jamie?
I personally haven't experienced this, so it's good to hear from Adnan. But I know that we're going to face injecting higher volumes as well. So the intraocular pressure rise has been discussed, but overall the data suggests that it's not really...
And Macugen and the current new therapy was a higher volume, and we kind of were already dealt with that in the past.
Correct, and some of the new drugs that you have to inject a full 1 milliliter, sorry, 4.1, actually what was exercised was just to hold the cotton tip for 20 seconds, 20 seconds, stop, another 10 seconds, and then it's kind of a massage, and then it goes very easily, so I think that should not be a problem. I think your point's well made.
So talking to my US colleagues who have access to complement inhibitors, that cotton bud approach, because they then treat continue the complement inhibitor and the anti-VEGF within a half an hour with the cotton bud, or even closer than that.
Yeah, Jamie, I want to ask you, we are talking now about something new, right? It will need 2 injections, we need to approve a drug, we need to pay more. How much better does the addition, the combination need to be for you to adopt it in your clinic? If I'll tell you that it improves by 50 letters, I'm sure that yes. If 0 letters, I'm sure that no. Where is the sweet spot?
Yeah, so I think from clinical trials, we talk about maybe at least 3 letters. For example, in the PCV side, we've had the Everest 2 study when we compared combination to monotherapy. And the cutoff point at that time was 3 letters, considered as a meaningful in terms of trial outcomes. But in clinical setting, I think every patient is different. There could be some patients who are happy with 55 letters and doesn't care. But really, there are the patients who are much more discerning. And to those patients, I think every letter counts. And the difficulty is when we have no option to improve anything, then we're really stuck right now.
So going back to that data that was surprising to me, that every letter drop per year over 8 years was associated with a 16% increase in all-cause mortality, that I'm now starting to realize even subtle visual drops over time build up. And we got very good phase 2 data, but what will be really exciting is what goes on much further down the line, given there's the potential to decrease CNV size, less fluid. So will the delta of benefit increase further over time? And being very UK and health economic, when you do a health economic modeling, you project over the lifetime of the patient. And that initial 3-4 letter difference may really amplify, since most of our patients in real world, as I've shown in the UK, no matter what treatment we've introduced in the UK, they're all tailing off after time point X, no matter how much we perceive extended delivery in neotherapies. So the extended delivery is not being associated with better visual acuity outcomes, and we hope a novel intervention which blocks VEGF-C and D may, but we have to wait for the trial data, but it is exciting.
I think what you said is very valid, and I think what pushes me is it's not only the number of letters, it's that all the data goes in the same direction. The percentage of patients who lost three lines, the percent of patients who lost 10 lines, the percent who gained these. So everything goes in the same direction. So I think it really brings hope that we will be able to exercise it in a beneficial way for our patients. How comfortable would you be to use the combination in a patient who is already treatment experienced?
I think that's slightly less clear, and I think we probably want more data. What we've seen in switching trials in the past, that initially when we've had patients on chronic treatment and we switched to a new drug, there's always the wonder of the new, and everyone says, oh, in my experience, when I give the new drug, the patient gets better. But what tends to happen when you give a new drug, you increase the frequency of therapy, but over time, and we did a paper on switching Lucentis to Eylea, that if you map a control group, after the initial transient increase, then it drops off. However, there was a transient increase. That means that we probably are suboptimally dosing, so there may be a potential for additional benefit from adding something else, given increasing the frequency probably improves things. So even though that, I think we probably need more data to do that, I think there may be potential benefit.
You see, I want to hear you too, Jenny, but in my opinion, it's the opposite. If I have a patient that is doing pretty well on Eylea or Lucentis, and I know that in the combination he's doing better, what's the big deal just to do now a combination? He's receiving the drug, he's not doing optimally, so to me...
Oh, no,
I'm just saying that I would be comfortable. Of course, you want to have trials and real-world data.
So that's a slightly different scenario. If you've got a patient that's stable on the old drug, no. And when we looked at the initial switches, the patients you initially switch are the ones who are doing not so well.
Correct.
And it's those patients that I think we do first rather than my stable patients. But I'd want more data for the stable patients, but for the ones declining, it would be a very attractive option for the same reason we switch drugs currently.
Okay, Jamie?
Yeah, I agree. Switches are always difficult, but I tend to be on that side, is that we're adding something. So when we talk about suboptimal responses, rarely is there a patient who is the total non-responder. So with the current way we switch from one to another, when we take away the original and replace it with the second one, sometimes it works better, but there's always a proportion that actually does even worse. So whereas in this case, we are not even taking away anything. We are adding purely. So from a pure, simple logic side of things, I'm very comfortable.
I think your point about switching and doing worse is absolutely correct. We've all got slightly burnt and you embarrassingly have to switch back again.
Okay, so Adnan, just to summarize everything that we said, who, in your opinion, would be the ideal patient for combination therapy with Sozinibercept?
I think, basically, assuming the phase 2 data plays out, and as you said, everything goes in that direction, I would probably say everyone, because most of the visual acuity change is in the initial period. Now, obviously, if you catch somebody with incredibly good vision, there's not a lot of room for an improvement, but there may be other effects we haven't read out yet, because if you decrease the CNV size early on, would that reduce the treatment burden in the future? So there's lots of unknowns. But anyone that has decreased vision, I would almost argue it would be attractive if there was superiority to use the most superior intervention.
Naive patient, you're saying? Jamie?
I would add to that, I agree with what you said, but even with those patients who have very good vision to start off with, what Anat showed on the monotherapy, we forget that 7% lost 10 letters or more. I was astonished to see that, because
But we know that the patients are losing vision. We know from the 5-year CAT trial. We know from many trials, the patients are losing vision at the end of the day.
Yeah. So even if patients are starting off with very good vision, doing this combination really reduces that risk. And 7% is not trivial at all. So I think I'd be quite happy to use this approach for all patients.
Thank you very much. Thank you for the discussion. I think the whole retina community is happy to have something that is not only anti-VEGF-A and that has the potential to improve vision. So I would like to thank you very much and to thank the listeners and Optea for sponsoring this symposium. Thank you.